Okay, so 52 is you're doing a colonoscopy, and they haven't done the prep well. So you stop the procedure because you can't complete it because you can't get the visualization. 53, discontinued, is let's say you're going to do implant an artificial heart. You crack the chest, you open the cavity, but as you do it, the patient starts to crash, and to complete the procedure and put the heart in and take the other one out, you're probably going to kill them on the table. Whereas if you just close back up, they may live a little longer. So you're stopping the procedure because it threatens the well-being of the patient. So 52 is there's something that's preventing the completion of the service. 53 is you stop because to continue threatens the patient's life. Okay, all of these, so we're moving down, all of these codes, there's three components to them. There's the pre-op work, there's the operative work, and there's the post-operative work. And the way I like to explain this is, Lazaro is our surgeon. All he likes to do is slice and dice. We have Adriana, who is internal medicine. She likes to be with the patient and make sure everything's okay, and so they partner up. And she handles everything up to the operation. Lazaro does the operation. She handles everything after the operation. So for them to bill, she would bill the surgical codes with modifiers 55 and 56 for post-operative and pre-operative management. And Lazaro
56.
would bill for the actual
54.
surgical
54.
components
Okay.
with modifier 54. Okay. 57 actually goes on an E&M service, evaluation management service. Okay, we've talked about 59. 59 is the staged or related, and like I said, I call it the decision. If you have to make a decision to do a more extensive, the 58 goes on the procedure that's analytical, diagnostic, like a biopsy. That gets the 58. And the main code would go first, and then the biopsy with the 58. Okay, 59 is the modifier of last resort. There's nothing else to use to describe it. Going back to where I was saying, let's say you had to do a biopsy here and here. Well, the code isn't going to distinguish where on the extremity you took the biopsy. So to distinguish that, you have to put a 59 for the second biopsy. Because otherwise what's going to happen is the editors at the insurance company and Medicare will kick out the second unit. So that is the modifier you would use instead of 51 in this case, just to show that it was a distinct procedure. And then you get into stuff that's you may see on the tests, but when you have two surgeons, you use a modifier 62. 63 is straightforward, procedure performed on an infant of less than 4 kilograms. 66 is also fairly straightforward. You got, it's usually multi-system, and you've got a whole team of providers doing surgeries together. Then we get to the more complicated stuff. Okay. So 76 is a repeat procedure or service by the same physician or other qualified healthcare professional. So, let's say you do an arthroscopic procedure on the knee, and you don't, the patient comes back, you examine them, and you've got to go back in and repeat the procedure because evidently there's, it's not fully cleaned. You would then put the modifier 76 on it. Go ahead.
But has to be the same physician?
It has to be the same physician. Okay. Let's say it's being done in the hospital.
Or all are qualified.
Yeah, but with the same person. For example, is a...
Yeah.
Yeah, the same person does it. The neck 77 is basically the same thing, except it's done by someone else. So 78 is an unplanned return. It's kind of the opposite of 58. So let's say I forgot there's a term for, let's say you do a cabbage, but one of the vessels you don't get a good match on one of the vessels, and they start to bleed internally. Obviously that's not planned, but you're taking them back in to redo it and repair it.
It's like a complication, yeah, post-surgical complication.
Yes. 79 is the same type of thing done by someone else. Then you've got the assistant surgeons. And so that's a quick rundown of how what these modifiers do. Just to quickly go over, because this is partly related, modifier 24, let's say you do a procedure on the knee, but the patient comes in, oh shoot, okay, first, with every procedure there's a post-operative period. It can be 0, 10, or 90 days. So during that period, the follow-up E&Ms, you can't charge for them. They get reported with 99024. But those are E&Ms related to the procedure. So let's say I had my knee scoped and repaired, but I came in to my orthopedist, and now my elbow is troubling me. And it's in the 90-day global period where for the surgery. Because it's not related to the knee, the E&M for that elbow injury can have a modifier 24 on it, and they can charge for that. And that's because it's unrelated to the knee injury. But that only goes on 24 only goes on an E&M code, an office visit code. There's also the decision for surgery, and Medicare will have you use 2 different E&M codes. So for a major surgery, anything with 90 days, it's modifier 57, decision for surgery, and that goes on the E&M code. And they'll also tell you to use for 0 or 10-day procedure, modifier 25.
Wait. So the 57 is a second procedure in the
No.
United States? Or?
No, it's, so you're my orthopedist. I come in, I tell you I've been having a lot of knee pain for the last 6 months.
Mm-hmm.
And you do an evaluation, you take the x-ray, and we get back together, and based on the x-ray or the MRI, whatever diagnostics you do on my knee, we make a decision that, okay, I need to have arthroplastic repair. I need to get my knee repaired because there's a tear in the meniscus, there's whatever. The pain won't go away unless you have the surgery. So I go, I can live with it, no, I want to repair it. And so at that point, the doctor and the patient make the decision to go in for surgery. On that E&M, where you make the decision to go in for surgery, you put the modifier 57. The reason you do that is because when you go in and then do the surgery, what they might do is look back and say, well, there's an E&M included in the surgery, and they may take that E&M away from me without the 57 on it. But generally, the E&M that should be taken away is when the doctor goes in to perform a surgery, they don't just, grab someone out of the hall and, they go to their patient, they examine them, and make sure they're okay that day to have the surgical procedure. And so that E&M is supposed to be bundled in, not the actual decision. And so that's why we have the modifiers for the E&Ms for the decisions. Medicare rules state that modifier 57 is for major procedures, modifier 25 is for minor procedures. And they define minor procedures as 0 to 10 days, major procedures.
25 is minor
Minor
procedure,
procedure.
and
Right.
24
57.
57
57
is major.
major.
Um,
And then 25.
So for, any of the complicated procedures, repairs, fractures, a lot of the heart work is going to get a 90-day global. Those will be considered major. Anything simple like a biopsy, simple closure is going to get 25 because the time afterwards that is routinely associated with the healing period is very short, whereas the time the healing of a fracture or something, the more complex procedures is much longer. So anyways, I thought we ought to go over those because they do play a little role in what we're talking about today.
Oh my. Yo creo que es más grande que tú estás diciendo que va a pasar.
For example, if we go back to the 20,000 codes and we go to, let's see, 20610, 20,006-100. You notice next to it, it has a blue up arrow. And I mentioned this, going over this partly, the blue up arrow means that code was revised this year. So if you look at the bottom of the page, has all of
The blue
the,
one is release code, and the red
This
one is
year.
new code. Green is like the triangle, contains new release.
yep. And then,
Modified.
okay, so, but arthrocentesis, aspiration and or injection of a major joint or bursa without ultrasound guidance is a minor procedure. Okay, so let's say you're doing an evaluation and management on this patient for hip pain, and it can be relieved with a Kenalog injection or some other type of injection. And you're also doing some other things that day in terms of the evaluation and management of the patient. What you would do is on the evaluation management code, you would put modifier 25, and then you would also bill the 20610 code as well as whatever you would bill them for whatever you injected. So that's just a quick example. The same with trigger point injections. Let's see. A lot of these codes, I mean, they're straightforward, and you would understand them better than I would. I just have to look for keywords. 20615, aspiration and injection for treatment of a bone cyst. You understand what that is on a medical level. I look for keywords in the documentation. So when we get to 20664, it's Halo application. Okay, that's going to be a much more complicated procedure, and as we go through here, these fixation devices for the healing of fractures, those are going to have the 90-day globals. So when you do the E&M, you would put a modifier 57. Odds are, in terms of this test, what they're going to ask you about is just the application of the Halo. They're going to give you an op report describing the application of the Halo, and then or the fixation. And so you just have to be careful of that it meets it meets the definitions. Some of this I don't understand. For example, what is so 20802 replantation arm complete amputation? So I assume that's the an arm that's been amputated.
What is a minute of replantation? Okay.
I heard the Leonda someone is waiting for head replantation. Yes, I heard that.
Yeah.
He's
We have that in
from-
the news.
He's living, I don't know, he's in Europe. He's suffering maybe from AML. He said, I don't have another opportunity. So he's waiting for some surgeon that said he's unable to do that.
Yeah.
Head
Yeah.
People crazy.
From Russia, is a guy. From Russia.
Yeah, crazy. Yeah, he's from Russia.
Crazy.
From Russia.
Crazy people.
He's from Russia. Yeah.
Very good.
You hear that?
Yeah, so
Yeah.
That would,
We have to be careful with Fidel Castro. Yeah, maybe then take a new job, a strong job, and put the same face. Oh my gosh!
That's crazy.
Imagine that Fidel 100 year war.
I can't imagine that at all because how is possible that because you can take my head and put it in another person. But what about the spine? What about, it's very complex.
Yeah, and all of these systems that are pituitary gland controlling all the different.
Because the brain is
¿Te imaginas Fidel en un cuerpo de 25 años?
La médula, la médula, ¿cómo van a...?
That is the problem.
Yeah.
The
Look at
the spine connected to the...
We don't need the Fidel body, we need his mind.
Anyway, then you've got bone grafts. Okay. Again, when you'll get excision, just be very careful. Again, it'll be easy to identify the excision of tumors in bone. Just be careful because you have code 21011. It's excision of tumors, soft tissue of the face or scalp, subcutaneous. So basically, it's the face or scalp under the skin. So just watch the description so that you're in the right place.
Oh, so special, okay.
Okay, because like I said, last week we went over the integumentary system, and there was a lot about the excision of tumors in there. But you have to make sure. So in this section, you've got stuff that's just under the dermal, under the skin, and so it needs to be coded to the musculoskeletal rather than the integumentary system.
So depends on the size of the tumor,
Yeah,
also the size.
and the site, because you have face and scalp.
Less than 2 centimeters.
Yeah, less than two, more than 2
2
centimeter.
centimeters.
What is that? Ah,
This one.
2 of, yes.
And it also, the musculoskeletal is broken down by where in the body you are as well. Right now, we're just dealing with the stuff that's dealing with the head, the head. It's just kind of, but it all follows the same patterns in terms of fractures. Because, and what happens is we're just going to move down the body. If you look at code 21501, for instance,
Oh, drainage, deep access or hematoma?
Yes,
Yeah.
some soft tissues leak out.
of the neck and thorax. So, okay. And you find that, I mean, this stuff is essentially in the same order in terms of excision, revision, and reconstruction, fracture.
Dislocation.
And then you move to back or flank. And then they give extensive instructions
The spine.
for the spine.
Yes.
A lot of examples in this.
We need 6 years to do this exam.
Primera incisión, excisión, luego fractura, todos van así por grupo.
So
Excisión, división, reparto.
With some of the-
mismo orden, por partes del cuerpo.
So ahora hay que codificar.
So with the examples,
So, I'm sorry, you have a patient with a fracture in the bone, and you have to do the coding for the equations. You have to follow up any step, you know, like incision, then you have to go in directly to the fracture, or you have then to do the suture, or,
The closure would not be included.
Okay.
That's part of this surgical pacture.
okay. So you have to use other code for the suture, or,
Unless there's something very unique about that closure,
okay,
it's going to be included as part of the surgical package because it's.
just one code for everything?
Yeah,
Okay.
so if you have an open procedure where you go in and you,
Right.
and this gets more obvious like when we get to, it's easier to talk about, for example, total knee replacement. That, it's an open procedure
Right,
and they insert the prosthesis and then they close it back up.
all right,
Simplified. That closure, unless there's something very specific about that, is part of the surgical package.
okay.
If there's something that's very unusual about that closure, then you would report it. Okay, here, these are actually good examples to read. So the second example specifically, you have a posterior arthrodesis of the fourth lumbar to the first sacral, utilizing morselized autogenous iliac bone, graft harvested through separate fascial incision and pedicle screw fixation. So they tell you to report as 22612,
614.
4, and what, so,
Behind this.
what I want to do is flip back, so
12. Say, look, arthrodesis, posterior, posterolateral technique, single level lumbar with lateral transverse technique.
So when you look at the 22612 code, it's arthrodesis, posterior or posterolateral technique, single level, and it's the lumbar. So you would, next to the 22614 is each vertebral segment, but it has a plus sign, so it's an add-on code. And
You have to report all of them, or you're gonna take only one?
No, all.
you would report
All.
all of these codes. But kind of what I want you to see is the 22612 is for the first one, and then that 22614 is an add-on code.
Yeah, but like, how many levels are it? L4, L5, and 6-1 are 3 level, right?
Right.
So if we take the 22612,
Just for the
lumbar
lumbar.
is
For the lumbar,
L4, right?
X4. right?
L4. And for
L4.
L5 is,
For X1. Okay.
yeah, and L5? That is my question. Because
So,
But I think what the point, the
so
initial
you
point.
would
is that-
actually put it I would put it times 3 because it's per each. So
Right.
4 is the first one,
Mhm.
and then you have 5, 6, is it 7?
no,
No, 4,
So-
5.
it's L5
4
and
and 5.
X1.
Mhm.
Okay.
Here, if.
Oh, okay, so-
For L5 and S1.
Okay, so, all right, that's where that's coming in. So,
22614, porque son dos vértebras más, esa es mi
Lumbar.
pregunta. Mi pregunta es esa, dos veces porque son dos
Eso
vértebras
quiere-
más.
ese lado del punto. So do you have to call each a vertebra, or you go into the start point or to the end point?
so what's happening on this is,
You start in the the L4,
For example,
and then it's X1.
L5, L4,
L5,
L5,
and
and
S1.
S1. So for this one that is single is 320, the first code.
212,
220, oh my god.
22612, no?
22612,
Lumbar,
right?
just lumbar.
226,
Yes.
and then is 222.
Pues el lumbar, yo pensé que para lumbar no solo.
So the lumbar is the
Just one
segment,
code.
is nobody.
It's not by no, it's not by one. It's just for the segment, for the lumbar segment.
No, but it's
Right.
a vertebra, that is not question.
Porque dice
You understand me?
Yeah,
226.
and they did not report the units on this.
Each additional vertebra segment is for segment. Look aquí.
Okay, segment, o sea, lumbar
for
segment,
segment.
sacral segment,
Mira aquí,
thoracic
¿no?
member, okay.
Este pone dos.
No, es aquí.
Busca la dos,
Bueno.
117. Aquí,
Okay.
mira aquí. ¿Dónde? Each additional segment, it is sanitary in additional to coma
Is nobody,
No,
vertebral body,
no,
is segment.
no segment.
¿Sí? ¿En serio?
Eso voy a subir, no voy a marcar porque
Son todas una provincia.
Entonces,
Explícame eso.
segment.
es por segmento, no por corte.
No por cuerpo vertebral. Yeah, it's for segment, like thoracic segment, lumbar segment, no for
Yeah.
body.
Y for each segment that you are going to do the sí, mira. Something like this. Oh, here it is.
Hubiera dejado para explicar.
Hmm?
Hubiera dejado para explicar.
So for, with this example, you know, I like it, but I don't.
¿Cuál es?
Because, so you would report 1 unit of the 22612, and you would report 2 units of the 22614.
Supposedly, right?
Right, because it's for each segment.
Right.
Okay.
Is that it?
For segment.
No, but he said that you had to report 2 units for 22614. 2 units, he said that.
So how can you do that? You put it twice, the two,
No, you put a /2, right?
or modifier? No.
No modifier, these are add-on codes.
Okay.
When, I really need to bring a CMS 1500 form.
She got it. Oh, I have one here. Do you need the guidelines? The IC9 guideline? No.
No, a CMS 1500 form is the old paper billing system.
Okay.
And what you would see is that you have line items, okay? And on the line items, you list the code separately. And then there's a units for it, in addition to the modifiers. So with these, the codes that get listed in this example are all add-on codes. But they're not giving you the correct units, because obviously, as she said, it's multiple, you have 3 different vertebrae, so 3 different levels. So you would have the 22612
For
as,
sacral.
and that would be just a unit of 1.